We'd like to start the second presentation. The next presentation will be presented by Professor Yaseen Arabi in Saudi bin Abdulaziz University for Health Sciences, King Abdullah International Medical Research Center. He is currently the principal investigator and co-investigator on several multi-center randomized controlled trials. He has been involved in MERS and COVID-19 research, and he has over 450 publications, including articles in leading medical journals. He is currently a section editor for intensive care medicine on the editorial board of several journals. He received multiple grants and awards, including the Barry Shapiro Memorial Award for Excellence in Critical Care Management, Society of Critical Care Medicine in the USA 2011. So we welcome Dr. Yaseen, and the floor is all yours.
Thank you very much, Mr. Muhammad, and thank you for the organizing committee for inviting me to present in this very important conference. I'm grateful for you for the invitation, and I listened to the previous excellent talks, which really paved the way for this presentation. So what I'll be presenting on the role of adjunctive intermittent pneumatic compression for venous thromboembolism. As my colleagues mentioned, DVT in hospitalized patients, and especially in critically ill patients where I work, is very important. This is from post-mortem autopsy of a patient who died suddenly and found to have a large, deep venous thrombosis. So it is one of the major reasons for sudden death in critically ill patients and hospitalized patients in general. And this is an area of interest for a long time now. This is one of the early randomized controlled trials published in 1972, where patients were randomized to receive heparin versus no heparin, patients having major surgeries. And since then, we have learned a lot about the value and importance of pharmacologic thromboprophylaxis, but the data on mechanical thromboprophylaxis are less strong. So mechanical thromboprophylaxis, we have two major ways. One on the left side is the intermittent pneumatic compression, and this is a device that applies pressure intermittently and gradually to the legs and sometimes up to the mid-thigh to stimulate venous blood flow. And on the right side is the graduated compression stocking, which also apply pressure on the veins to reduce venous stasis. My focus will be on the one on the left, the pneumatic compression device. The data on the graduated compression stocking have been very limited, and in critically ill patients, especially in medical patients, did not show to be beneficial. So, as my colleagues mentioned, thromboprophylaxis has been shown to reduce the risk of DVT. So, in critically ill patients, systematic reviews of randomized controlled trials showed that pharmacologic thromboprophylaxis using unfractionated heparin or low molecular heparin reduced the risk of DVT by 50%. So, this is important. It does not eliminate the venous thrombosis, it reduces the risk of DVT. And as a result, the clinical practice guidelines recommended that pharmacologic thromboprophylaxis should be used in all critically ill patients. But even with the use of pharmacologic thromboprophylaxis, there are patients who develop clots, and different studies have shown that 5 to 20%, depending on the population, would develop DVT even with pharmacologic thromboprophylaxis. And hence, it's important to ask ourselves what would be the role of adding intermittent pneumatic compression devices. Now, what do we know about intermittent pneumatic compression? We know that these devices, if they are used in patients who are not getting heparin or low molecular heparin, they do reduce the risk of DVT by about 30%. But if a patient is on thromboprophylaxis, the data are less, we don't have that much data. Up to our clinical trial, the major trial was CLOT3, which is done in hospitalized patients with stroke. Intermittent pneumatic compression devices reduced the risk of DVT by around 30%. But this trial included patients who were on heparin and other patients who were not on heparin. So it's kind of mixed population in terms of pharmacological thromboprophylaxis. And I think we all agree, and clinical practice guidelines do recommend that if the patient has contraindication to pharmacological prophylaxis, then use intermittent pneumatic compression. But should we use it in addition to pharmacological prophylaxis? This question was open, and there is considerable practice variation. There are certain centers that almost use it universally with heparin, and there are some centers who don't use it at all because they think that there is no evidence. And this reflected also in clinical practice guidelines that provided inconsistent recommendations. And therefore, we plan to do the PREVENT trial, which is a trial that asking this question in patients who are receiving pharmacological thromboprophylaxis with heparin, unfractionated heparin or low molecular heparin, does the adjunctive intermittent pneumatic compression compared to pharmacological thromboprophylaxis alone reduce the incidence of proximal lower limb DVT? So critically ill patients who are already receiving heparin or unfractionated heparin, should we add pneumatic compression or not? This is the question that we are answering in the PREVENT trial. So the PREVENT trial was a multi-center trial, investigator-initiated, pragmatic, international, that was led by the Saudi Critical Care Trials Group, and we're privileged to have done this in 9 sites in Saudi Arabia, including multiple sites in Riyadh, including King Fahd Medical City, and my colleagues have done a remarkable job there. We had 5 sites in Canada, 3 sites in India, and 3 sites in Australia. The study was funded by King Abdulaziz City for Science and Technology and by King Abdullah International Medical Research Center, and we are very grateful to their support. Without their funding, this trial would not have been possible. This study was published in the New England Journal of Medicine in 2019 with my esteemed, and I was privileged to be part of this group, and we're pleased with the outcome of this trial. So what we've done, we included patients who are medical surgical trauma ICU patients, who are adults, and who are expected to stay in the ICU more than 72 hours and are eligible to get pharmacological thromboprophylaxis. We excluded patients who could not receive pneumatic compression device or could not receive ultrasounds regularly, because that was a standard procedure in the trial. There are other exclusion criteria listed in the slide. So we randomized patients to one of the 2 groups, either to receive pneumatic compression device that's on top of the unfractionated heparin or molecular heparin, or the control group, which is just continue with the pharmacological thromboprophylaxis alone. And what our protocol was to apply the pneumatic compression at least 18 hours per day. And we prioritized, we said for the units, we prefer that you use multi-chamber cuffs, because there are two types of sequential pneumatic compression, the multi-chamber and the single chamber. We said preferably use the sequential chamber, and the thigh-length sleeves if available. Foot pumps, which in some centers they have it, we allowed the use. And we continue the intervention until the patient reach an outcome, which is the DVT or PE is confirmed, or unless there is, for example, safety issues such as leg ulcer or ischemia, or if the goals of care have been transitioned to palliation, or until day 28 or ICU discharge. In the control group, we did not, so the control group would be continuing pharmacological thromboprophylaxis, but pneumatic compression would be allowed only if the pharmacological prophylaxis is stopped for some reason, patient bled or had a procedure, then during this period, pneumatic compression was permitted. And all the patients, and this is the strength of our study, is that in all patients, we did ultrasounds twice weekly for the whole intervention duration. Bilateral proximal lower limb venous thromboembolism by ultrasound, by certified ultrasonographer within 48 hours and twice weekly. And we standardized the procedure for the ultrasound by looking at 6 venous locations. The ultrasound was read eventually by radiologist who was unaware of the treatment assignment, and examination of distal leg veins was based on local hospital practices. Workup for pulmonary embolism and non-lower limb venous thromboembolism was at the discretion of the treating team. The primary outcome of our trial was the incident proximal lower limb DVT. So this is the DVT that happens after day 3 in the enrollment. DVTs that were detected between day 1 and 3 were considered prevalent, and they were not included in the primary outcome. They were included in other outcomes, but they were not included in the primary outcome. So the primary outcome, DVTs that are not prevalent, to exclude that the possibility that some of these DVTs may have happened, may have come with the patient to the ICU. Sample size was 2,000 patients, accounting for 5% loss of follow-up. 5% of DVT would have, 5% of the patients would have prevalent DVT, and we estimated that we'll have a treatment effect of 3%. We estimated that we're going to have a risk of DVT of 7%, and we'll reduce it to 4%. Well, that gives us a power of 80% and alpha level of 5%. We had a data safety monitoring board that reviewed the data after 1/3 and 2/3 of the patient population have completed follow-up. The study management was a very interesting journey. We had a lot of quality reports that sent to the sites. We had newsletters. We had quality reports that we sent to sites with detailed about the data collection, about the compliance with the protocol. And I'm grateful to all the study teams who have done massive amount of work on getting this study really high quality trial. We had 16 site visits conducted by the management team. We had one international site visit also. We had our team went to one of the international sites, and we had remote monitoring of all sites. We had data safety monitoring board reports and interim analysis, as I said. We had database was built by the outstanding team at King Abdullah International Medical Research Center, and had a lot of tools that helps in the database and managing the trial. So we're very happy about this. We have published the study protocol and the statistical analysis plan ahead of the final analysis in the journal called Trials. So that will give us a much more robust methodology of the clinical trial. Also, we had a study protocol for looking at the effect of screening by ultrasound as also published protocol. So this the consort diagram showing the patients that we screened. We screened in the trial 4-year period. We screened 16,000 patients for eligibility. Many of them did not meet the inclusion criteria because either they were not on pharmacologic prophylaxis, they are bleeding, etc. Many reasons, or they had short stay. So we ended up with enrolling 2,027 patients, 1,003 in the IPC and 1,024 in the control group. There were some patients who were excluded post-randomization. So we ended up with 991 in the IPC group, 1,012 in the control group. All of them were included in the intention to treat analysis, and as shown in this concept diagram. So this is the baseline characteristics of the trial. The average patient age was around 58. The BMI around 29. The majority of patients were medical, so around 79, 77%. There were post-operative patients around 13, 14%. Trauma constituted 7 to 8% because most trauma patients in the very short time window for enrollment had either bleeding or contraindication to get pharmacologic prophylaxis. Around 2/3 of patients were mechanically ventilated at the time of enrollment, and around 1/3 were on vasopressors. Around 58% were on unfractionated heparin, and 42% on low molecular heparin. Femoral central lines were prevalent in 15% of patients. And so this is the baseline characteristic, which were very balanced between the two groups. So the IPC was used as per the protocol in the vast majority, 98% of the patient in pneumatic compression. And our goal was to give it for 18 hours at least, and we achieved this and exceeded actually this. We gave it for 22 hours median, so even higher than what we planned. The control group received pneumatic compression during interruptions of pharmacologic prophylaxis, but was very short period of time, so the median is actually 0. The majority of patients received knee-length sleeves, and for a median of 7 days in the trial, so a good amount of exposure to the intervention. Other co-intervention shown here, for example, therapeutic anticoagulation was very low, 5-6%. Antiplatelets were given in some patients, around 30% of patients, aspirin. This slide shows the number of ultrasounds were done for patients. So it depends on how long patients stayed in the ICU. For patients who stayed in the study in the study for 1 to 3 days, they're supposed to get 1 ultrasound, and they did generally get 1 ultrasound. So the compliance with doing ultrasounds was very high. And on average, we wanted to do ultrasound every 3.5 days. And essentially, we achieved this. So we take, for example, patient who stayed in the study for 25 days or more, they're supposed to get 8 ultrasounds. And in fact, that's what they got. They got 8 ultrasounds on average every 3.8 days. So very, very frequent ultrasounds. So on average, 1 ultrasound was performed every 3.5 days in the IPC and 3.8 days in the control group. So the primary outcome, which was the incident proximal lower limb deep venous thrombosis, occurred in the IPC group in 3.9% and the control group in 4.2%. That was not statistically significant. And when we adjusted the relative risk is 0.93 with a wide confidence interval that includes 1. Adjusted relative risk was not much different. Adjusted hazard ratio was similar. Just incorporating site as a random effect was not also around 1, so no treatment, no effect. Adjusted accounting for the competing risk of death also was around 1. So all of these showing that the addition of pneumatic compression to pharmacologic prophylaxis did not reduce further the risk of deep venous thrombosis. This is the per protocol analysis on only the patients who received pneumatic compression. In the control group, only the patients who never received pneumatic compression. And this is show no difference again in the per protocol group. This is a Kaplan-Meier curve and it shows identical curves for the two groups, no difference between the two groups in terms of DVT. This is the per protocol analysis again. There is no difference between the two groups. The subgroups, we had pre-specified subgroups by the type of heparin, by being obese or not, by being medical, post-operative or trauma, by having heart failure or not, by having low or high ejection fraction, by having femoral or no femoral venous catheter, by being on vasopressor or not at the time of enrollment. And none of these showed a statistically significant difference. So all of them were not significant. all of them not significant. Then we did multiple sensitivity analyses to account for different cutoff points for defining incident DVTs. And if we consider incident DVT, the one that happened on day 1 or later, or day 2 or later, day 3 or later, all of them did not make a difference. For the missing baseline ultrasound, we have a few patients missing ultrasound. Again, did not make much difference. Restricting the analysis to patients stayed in the ICU for 14 days, again, did not make much difference. To address patients, very few patients who did not have follow-up ultrasounds, again, similar robust finding. To evaluate the effect of duration of pneumatic compression device every day, more than the median or less than the median, same treatment effect, all of them not significant. Secondary analyses or secondary outcomes, taking in consideration all incident DVTs, proximal and distal, there was no difference. Prevalent DVTs, again, was not different. All lower limb together, all DVTs, whether proximal, distal, incident, prevalent, no difference. Now we have much more events, 9% versus 8.4%. Pulmonary embolism happened in 0.8 versus 1%, was not different. VTE, all VTE together, so PE and DVT, which happened in 10.4% versus 9.4%, was not different. Non-lower limb thrombosis, which some people believe that the pneumatic compression devices can have an effect remotely by increasing fibrinolysis, again, was not different. There was no difference in mechanical ventilation-free days, vasopressor-free days, ICU-free days. All these were not different. There was no difference in mortality. There was no difference in composite endpoint of DVT and mortality, 23 versus 24%, no difference. One of the issues that was raised that sometimes pneumatic compression, placing pneumatic compression can lead for unintended consequence, which is limiting the mobility of patients because you put them on this pneumatic. So we looked at the highest level of mobility during the ICU stay, and that was no difference. So there is no evidence that having pneumatic compression device limits the mobility of patients in the ICU. So from that standpoint, there is no concerns, at least. One of the issues also that we thought about when we planned the trial, that because this is an open label trial, one issue is that people may do more or less diagnostic workup for pulmonary embolism if the patient is receiving pneumatic compression device. And so we looked at the number of diagnostic tests patients receive, and we found that, for example, CT scan of the lung for PE was not different. Perfusion scans was very rare to be done. Transthoracic echo, esophageal echo were not different. So there was no anything to suggest what's called ascertainment bias, that people tend to test patients more if they are on pneumatic compression device or not. We looked at several other exploratory outcomes, like whether the DVT, whether the pneumatic compression, for example, reduce the extent of DVT instead of being bilateral, becoming unilateral, or number of veins involved, or being incomplete or complete. And none of these were different between the two groups. We also looked at central venous catheter-related DVT that did not differ. And we looked at distal DVTs that did not differ. Upper non-lower limb thrombosis, and I mentioned one of the mechanisms that people postulated for pneumatic is the increased activity of fibrinolysis. We could not find a difference in the non-lower limb thrombosis. Features of PE was not different between the two groups. In the CLOT3 trial, one of the reported adverse events was skin ulcerations, and we did not find any difference in skin ulcerations between the two groups or any difference in limb ischemia. So this was really a great experience. I think it was a great success to the Saudi critical care trial group, and I'm really pleased for the outcome, and I'm grateful to the opportunity to work with each one of the leads on this trial, who did fantastic job. I think this trial had made big impact on clinical practice. There are a few things to consider. Is that the event rate in the control group was lower than expected. We thought that we're going to have a DVT 7%. We had around 4%. So this may have reduced the power of the trial. The trial by design is unblinded. It's really hard to blind whether you are on pneumatic compression or not. We thought about this, but it's just not practical or even meaningful. We had very high compliance with ultrasounds. There were very few patients who had no baseline ultrasound or follow-up ultrasounds, but we did, and that happened on some weekends, but we did sensitivity analysis and we found that this did not make a difference. We used knee length or thigh length, but this as a pragmatic trial is very acceptable and improved generalizability. So our conclusion that in critically ill patients who are getting pharmacologic prophylaxis, we found no additional value of adding a pneumatic compression on top of the pharmacologic prophylaxis, as long as the patient is actually receiving pharmacologic prophylaxis. I'm very pleased to see this making it to the clinical practice guidelines. It has made it to the CHEST guidelines on prevention and diagnosis of VTE in patients with COVID-19. It has made it to the very recent guidelines of the American Society of Hematology for management of thromboembolism, prevention and treatment in patients with cancer, made it to the Japanese clinical practice guidelines for sepsis, made it to the Surviving Sepsis Campaign guidelines for sepsis, which just was published recently and was privileged to be part of it. But I think this, and there are other, the trial has been included in other guidelines and in multiple systematic reviews. And so this really speaks well to the coordinated and high level of care provided by all the participating sites. So this is a list of my friends and colleagues and who worked massively on this trial with their teams. And so congratulations to all of them and to their teams who conducted high level and high quality work, and I'm grateful to them. The same group is producing other clinical trials. We have several ongoing projects from the Saudi Critical Care Trials group, and I think it's making impact on clinical practice and knowledge. I'm also grateful to the Data Safety Monitoring Board who helped us through this journey. And of course, I'm grateful to the KMARC and CACST for funding the trial, and KMARC for the help in managing the trial, database, auditing, etc., and helped in getting this trial at very high level. And thank you for listening and for the opportunity today.